Thank you all very much. There are so many themes in everything that you said. So I'll think about pulling some of them out. But I heard each of you use language in particular ways, and either by drawing, an analogy or thinking about, how you're explaining, one side of the bridge to the other side of the bridge, or how you're explaining this from the perspective of people who sit in it and study it to the people who are making decisions about how to spend the money, about how to design the curriculum, about what to do in their countries. So I'd like to hear from each of you. In that, having to explain this to get people to see it, to believe in it, to understand it, where have you found some of those key language barriers or where do you have to change the way you talk about things in order to get people to see the importance of this convergence?
Yeah, thanks, Bridget. Well, I think frankly there's a huge difficulty with the term NCD, because I think that in common parlance, and you can look at this up in in Wikipedia, et cetera. If you asked what folks think it is, it really has a fairly narrow definition, essentially, of more or less lifestyle diseases related to overweight, lack of physical activity, et cetera, and their associated cardiometabolic problems. And I think that for folks in the infectious disease world, that I think broadly, maybe this is an overstatement, but have been focused on the poorest billion. And certainly if you look at things like the Commission on Macroeconomics and Health and different framings around infectious disease priority, they were focused on those populations. There's sort of a disconnect from an equity standpoint in focusing on that particular issue. And if you really just exclusively looked at the burden of those NCDs defined in that fashion, it's smaller than what is claimed. And if you take the GBD, the global burden of disease definition, or the definition in global health estimates that WHO uses, which of course include a much more diverse, heterogeneous set of diseases, which is like most of the ICD codes, as we said. And so I found that one of the things that's helpful with my colleagues, say at Partners in Health, which is an NGO which is largely focused on the rural poor in Africa and Haiti, is getting more specific about what the priorities are and how at a very disease-specific level, and seeing the analogy between that and things that have been priorities in the infectious disease world. So, in some ways there may be more in common. Maybe for somebody that whose life is focused on dealing with HIV or TB or childhood illness, some of these conditions like rheumatic heart disease or peripartum cardiomyopathy within cardiovascular disease, or type 1 diabetes, things that are killing children, congenital diseases, surgical conditions like appendicitis or strangulated hernias, which really don't fit the conventional framing of NCDs, actually may be more consistent with the implicit sort of ethical paradigm that folks in sort of traditional kind of global health, infectious disease focused global health have operated under. I think that the term NCD in that way has been kind of unfortunate in that it's made invisible that opportunity, actually. And I think that even when we see the natural conversations that people strive for between linkages between infectious disease and, quote, NCD, is always in those conventional terms. Largely, right, it's like TB and diabetes. It's, TB and overweight, or HIV and hypertension and diabetes, which clearly those are important issues, but they're a relatively narrow subset of what truly the issues are at the interfaces of NCDs very broadly in HIV. So I think that we need some kind of significant change. Either the NCD category needs to truly embrace the full diversity of that, or we need to be talking more specifically about what we mean in the subset of NCDs when we're discussing that. So that's my view in terms of language.
Yeah, I guess a couple of thoughts about that. I mean, one that is, I think, part of the elephant in the room metaphor here, of course, is that convergence or integration, or pick your term, there's a few others around, is something we don't all have well defined. We don't have an agreed definition of what convergence might mean. For instance, the Commission on Investing in Health, the Lancet Commission on Investing in Health report that came out in 2013, they talked about a convergence, and that was a convergence of poorer countries towards the achievements of wealthier countries in terms of maternal and child health and infectious diseases. They were looking at the sort of traditional areas of global health and said it is possible for poorer countries to converge on the levels of mortality and burdens that have already been achieved in higher income countries. That's a very valid convergence point, and they laid it out clearly. That's not what we're talking about here. So that's just a simple example, but I think the integration that we have in mind, I think we do here in talking about the convergence in this context, is still not well defined. So that's one point, which I hope we will talk about a little bit more. But I want to talk just a bit more on language, both in terms of language that is used and language that is unspoken but implied or sort of under the surface. And to Jean's point about the term NCDs, nobody loves that term. There's lots of reasons not to like it. But in the early days, if you will, I mean, NCD's been around for a long time. It's not like they were just invented, when the NCD Alliance was created or when the UN had a high-level meeting. But there needed to be identification around a term for a community to form, for the coalescence of ideas and actions and advocacy and so on to be effective. And I think that the term NCDs achieved that at cost, definitely at some cost. So the language that's used does identify us, does put us on one side of the room and other people on the other side of the room. And that is a real big problem because, I'd be really interested to hear what the folks on this side of the room think NCDs are and what they think when they think about NCDs. And that takes me to the stuff that doesn't get said very much. And I've said this before in public fora, so I'll say it again because well, I won't say it because it's rude. It is rude, but I will say it in spite of it being rude because I think that it exists, which is the mentality that NCDs, not when you're in Uganda, but in this global community that some of us stroll around in, that when you're talking about NCDs, you're talking about rich, old, white, fat man problems. And that doesn't get sort of said openly, but there's still a lot of that around. And I think in other parts of the health community, global health, not country health, community and global development communities, the lifestyle things that Jean referred to, the blame. So there's cognitive issues around how we understand these problems that I think are sometimes barriers to us dealing with them in very effective ways. And I won't go into all the cognitive aspects that I think challenge us, but we might come back to that later.
Thank you. Nelson.
Yes, these terminologies, non-communicable diseases and infectious diseases, are so deeply entrenched into...
Can you push your button? I think it didn't come on.
Oh, sorry. Yeah, so these terminologies, infectious diseases and non-communicable diseases, are so deeply entrenched into the education system, into our day-to-day life and communication, so that it really contributes to the difficulties that we may encounter. The ordinary person out there, even health professionals, health workers, they think about non-communicable diseases in one way and infectious diseases in another. So unless we can, in the future, use terminology that doesn't bring up that kind of dichotomy between the two, we will continue to experience challenges. However, recent events have started to give us an opportunity where to demonstrate to people that actually these two entities are related in some way. You know very well that there is vaccination of HPV, so using HPV vaccine to prevent cervical cancer. People understand what cervical cancer is, and with the introduction of HPV vaccines, you then begin to show that, look, an infectious agent may be responsible in the long run for causing cervical cancer. We talk about vaccination with hepatitis B vaccine, whereas hepatitis B vaccine has been long used in the developed world. It's only in about the last 10 years that HPV has been introduced in the routine immunizations in most of our countries. But again, talking about HPV vaccine that, it can prevent cancer, they begin to see the link between infectious disease and cancer. And a third disease we can talk about is Burkitt's lymphoma, which is very prevalent in children in Uganda and a number of countries. Again, talking about the link between malaria and Burkitt's lymphoma, Epstein-Barr virus and Burkitt's lymphoma. Again, that helps us to explain that actually there's potentially linkage between infectious diseases and non-communicable diseases, in which case we lay the ground for, approaching those two sets of conditions as one, and that the same health system should be able to address the two.
Dennis, thoughts on language? I'm just saying, Dennis, thoughts on language?
Great. Look, the global health agenda, it's interesting. It's really an agenda that was defined by the epidemiologic priorities of the 1980s and 1990s. And you see agencies like USAID and our counterparts in the UK or Japan, Australia, wherever. The agendas that we're pushing now have not evolved and kept pace with changing epidemiology. And part of that is reflective of, again, going back to the US government, we've received funding based on congressional earmarks, which gives you absolutely no flexibility to move and evolve and to adapt to what that changing epidemiology is. So even for all of the well-intentioned efforts being made by appropriators on the Hill, they are still looking at the world as if it were 1980, 1990. So the issues about immunization. I mean, it was clear in 1980 that there were far too many children dying from vaccine-preventable diseases. It's been extraordinary, the progress that is made. There's still an enormous amount of progress, but the issues, the other issues that are not being attended to really are a consequence of that inflexibility of the paradigm. The World Development Report in 1992 really was transformative in helping to argue what sort of the cost-effective packages were for being able to deal with the global burden of disease. What we haven't done is been able to go back and revise that and look much more effectively at what would be a co-package that would look at this interface between non-communicable and infectious diseases. So I don't think until we have that equivalent kind of evidence base that the World Development Report generated in 1992, that evidence base is what really propelled the extraordinary increase in global funding, global health funding around the world. And it's being able to have an equivalent kind of documented evidence base that allows for sort of a shared understanding of the burdens and a shared understanding of the actionables that can deal with those burdens, and being able to talk about them in cost benefit ways that has enabled the kind of funding that's been available for largely maternal and child health, moving and beginning to look at the larger population and the larger challenges the population face. There isn't, again, that kind of well-explained, documented presentation that can be made. So I think until we have something like that, it's going to continue to be a very difficult transition. It's not either or, and that's why, this issue, it's not about infectious disease, it's not about non-communicable, it's understanding the larger ecosystem that's out there and being able to appropriately address it.
You had a thought sparked there, and then we'll open it up to the room.
Well, I'm sorry, I can't let that go by, Dennis. I'm sorry, there is an evidence base. There was a revised second edition of the 1993 World Development Report published in 2006, Disease Control Priorities, second edition. And in fact, a third edition was just finished as of 2017. I spent 7 years of my life on that. It was led again by Dean Jameson, who led the WDR. There is an extensive body of evidence on cost effectiveness, including packages of care for low resource countries, high priority packages of care that have been costed. And it is all there. And you're right, it's important. It propelled a lot of funding within the MDG era. That funding, we know where it went, but we are in a new era and we have the evidence base. So I just have to put it out there. It's all online, it's all free, dcp3.org. Jean was involved.
Okay, if I could
Others
just-
were involved.
I couldn't help but
So-
smiling also.
Yeah. Then, obviously, I'm among that population of people, as are our appropriators on the Hill, who are not as cognizant of that great work. And I think that issue of communication and articulation, why that isn't a much more central part of the discussion. So it's great. It's my own ignorance that speaks to that. But count me among the majority in terms of being ignorant. And why is that the case? Why is it the majority ignorant of it? In the 90s, that report moved very quickly into the political discourse. And evidently that's not happened with this. And why not? I mean, what will it take to make that a much more central part? So if the evidence base and the packaging and the arguments are there, then clearly the kind of outreach to the policymakers needs to be revisited in a way that allows that kind of rethinking of what health priorities are.
Like, we could have a whole 2-day conference on that question of why, even evidence that's well articulated isn't entering, and we'd probably need the policymakers and the appropriators to be in the room for those 2 days. So I'm going to open it up to all of you. We have the roaming microphones. Please, if you have a comment, be sure to say who you are, your name and your affiliation for the sake of the webcast and also the rapporteuring. So I welcome you to raise anything, really. If you have a comment on these issues, or if you have something that you would like this panel to dig in a little deeper on, or something that didn't come up yet that you think is important. Or if you have a brilliant, answer, and you can fix everything for us.
No brilliant answer. Kathy Nagler from the University of Chicago. So I just wanted to discuss a little more this definition of lifestyle diseases, because in the kinds of diseases that I talked about and Rob Knight talked about that are influenced by changes in the microbiome, these are not diseases of old fat white men. They cut across all segments of the population, and they're also not, you could call them lifestyle diseases, but they're not voluntary lifestyle choices. They're societal lifestyle choices. So all of the things that have led to the changes in the composition of the microbiome over the last 30 to 50 years have actually been recommended by the medical advisory boards, by the societal advisory boards. For example, the use of antibiotics, the switch towards processed foods. So it's a different way of looking at that definition of what a lifestyle disease is. And that's what I wanted to bring up.
Hi, it's Miriam Rabkin from ICAP Columbia University. I think we're talking about the wrong elephant in the room. And I just wanted to echo something that Nelson said and maybe come back to it, because I think it also has to do with language issues. I think the elephant in the room is weak health systems, right? You can't treat either communicable or non-communicable disease if you don't have a health system, if you don't have health workers, if you don't have a system that is trusted, that provides quality services, that provides affordable services. If you're not there, it doesn't matter what the health threat is, right? If people won't come to you, if people burn down your clinic, whatever the barriers are, if they can't afford to get there, if the bridge is washed out, it doesn't matter, none of the rest of this matters. And I do think that there's something deeply unsexy about the term health system. It may be vague, it may seem like a black hole, it may seem like a boondoggle or whatever, but that's the elephant in the room, is that we don't have the people, the trained, capacitated people in place who have trusted relationships with communities to identify whether, to get people to come to say, do I have a hemorrhagic fever, do I have, blurry vision from my diabetes? So I just want to sort of challenge us not to forget that and just echo Nelson's great point.
I was just really impressed as a kind of an outsider, John Harley from Cincinnati, that you're able to have a forum on microbial threats and concentrate on non-communicable diseases. I mean, that's a huge success. The huge success is that we have the capacity to deal with the communicable diseases enough to have the bandwidth to even consider other things. I mean, I heard talks about 40 years ago where the entire hospitals were completely filled with AIDS patients. And, that's not, I don't think that's quite the case anymore. We have the capacity to deal with tuberculosis almost anywhere in the world. It's not the lack of knowing what to do. It's the systems that you're talking about that are in place that are inadequate. But the very fact that you're now considering these other disorders is a measure of success. And I think the whole community should be congratulated.
Sorry. Go ahead. I'm blind to this end. I'm sorry, so I'm going to go over there and back to you.
Hi, just want to really echo the last two comments. Mihir Rahman, I worked at the Autism Science Foundation, but now I'm largely focused on care delivery improvement here in New York. And I think what's been missing in a lot of conversations I've been a part of, I've had the fortune to be a part of, is this lack of health literacy that is really prevalent, not just in local context, but in the global context, and doesn't seem to be entering the discussion as often as it should, especially because, we have the knowledge to talk about these things, but often the patients we're working with don't. And we don't strive to make it as accessible as it could be, and as much as it could empower the patients to be self-advocates and to also better articulate what their needs are and how we can better help them and better serve them. So I'm just wondering, what do we do to improve that, and how do we do that on scale? Because I want to hear more about that, and I want to see it actually being addressed.
I'm capturing a couple things that I'm hearing that I'll come back to you guys for, but let's hear from a few more people first.
At the risk of adding another elephant into the room, I can't help but think convergence to what end? And I think it's important that we're clear on that, because are we converging in terms of, trying to converge in terms of how we treat co-occurring diseases? Are we convergent in terms of how we screen and secondarily prevent? Or are we convergent in terms of how we primarily prevent? Because it always worries me when we default into talking about people as patients as if we all necessarily patients. So there is an importance, and I agree at the point earlier around the health systems and the importance of the strengths of the health systems. That is in the context of people as patients. How are we thinking about convergence in terms of keeping people people? Because that's a different, that is an even more challenging space, but really a space that we can't afford not to, because we have to somehow converge in terms of the science of primary prevention and work out how to slowly close the tap instead of working out just how to plug the leaks in the bucket, as it were. So just hearing, I'd love to hear your perspectives on thinking about, really take your point, Dennis, in terms of thinking about the future, because to me, that is one obvious area of convergence. If we're on the ground and we're seeing these silos, actually, if we take a step up, it's, the silos have limited walls. To some extent, we can get above the walls when we look into the future. So are we thinking in terms of future-proofing health and healthcare delivery? Or are we thinking also about health-proofing the future? Because we have to think about those sides.
No, I think for this great discussion. I mean, what I've been struggling with a lot is I come from the perspective of really detesting the whole language of NCDs. Gene and I had this long conversation yesterday. I mean, you're basically taking everything that doesn't caused by a single microbial etiology and grouping them together. And I do think, to add to what you said about what convergence are we talking about it. So I look at it from the perspective of having worked in sort of higher level sort of health decision making, and previously directing all the disease control programs in New York, and then now working on similar types of issues in Africa. And for me, a lot of it is about the power of translating a message to policymakers to do the things we want them to do. And so, of course, the magnitude and precision of the association between the factor and the outcome is important. But I think that's the evidence base already exists quite clearly. What I think has been missing at some level, and this is not because the science isn't there, but as a communication, is how we translate how the intervention we know that the intervention is likely to have an impact on the outcome, but how acceptable is that, and how well does that resonate with people's kind of sense of true causation? And I think that while we all understand how the environment shapes and impacts health, I think it becomes very abstract for policymakers. And so where I'm getting to is all of this discussion yesterday. I don't know if we're getting too far ahead of the science or not, but to the extent that we can actually articulate, here is the scientific mechanism by which the environment and the refined foods are actually causing the damage, I think that's going to change the acceptability of these interventions at a policy level. Because I think the way we say it now, unfortunately, is just a little too vague and a little too, oh yeah, I get it, the environment impacts your health, but people don't really get it. But if you can identify an enemy to an extent, it's this bad microbiome that's causing it. And this is the mechanism. And so even though if your intervention you're recommending is the same, I do think it has a powerful communicating message. So I would consider this convergence, to me, the most powerful aspect is really your ability to message in a way that may be a little bit more clear.
Hi. I wanted to sit in the middle before because I'm not a clinician, but I've worked on both sides of the community and the academic side for many years, and with AIDS prevention, treatment, the whole continuum. And I was struck by the lack of your use in all of this of the terms convergence of prevention and treatment as a way of looking at the convergence across different types of diseases. Doesn't have to be, for example, there's a whole continuum of prevention points with respect to preventing HIV. And the locus shifts into the community and into the global realm at the prevention level, and it moves to the individual level and the need to deal with the individual as we go towards care. However, I will never forget that no more than 15 years ago at an AIDS conference, the term integrating prevention and treatment of AIDS was anathema. It wasn't done. In fact, nobody knew what you were talking about. And that's an amazing thing. And when you think about the fact that AIDS also has provided us with a whole set of insight, knowledge about the convergence of NCD and HIV, and how HIV leads to comorbidities, and how much we've learned about NCDs through HIV, how much we've learned about cancer through HPV. And there's been so many different ways, but I'm surprised that we're just thinking about it in terms of silos when we have other than silos. We have examples which have progressed much further than the top-down models of silos. I think we can look at disaster prevention as an example of something that could bring the NCD together with the HIV, whether it's biological, natural disasters. And we don't, in limiting the discussion to diseases and non-communicable diseases, rather than the integration of healthy living, or I'm not sure what the word is, but making the best of what we have in every environment by using what we've learned. And I don't think we do too well about using what we've learned across silos and adopting that to current situations, maybe from the bottom up in some places, but certainly not from the top down.
My name is Sarah. I work for New York City Health and Hospitals. It's the nation's largest municipal healthcare delivery system. And I just wanted to tease out a little bit more the health system part. So there's often this blur between, healthcare delivery and public health, and we know that they're two very separate entities. So when we talk about healthcare delivery, these are where patients present. So one of the issues that we often see in healthcare delivery is that policy and guidance is given by public health, and it's not well translated at the healthcare delivery level. And I think a prime example are obviously infectious disease outbreaks. So when we look at the measles outbreak that's happening here in New York, I'm sure everybody knows how it all started. And I think some of the issues that we have is that clinicians these days haven't even seen a case of measles, let alone Ebola, so they don't have any idea what they're looking for. So while we're given policy and guidance, it's not translated, well enough at the healthcare delivery level. So I just wanted to make a little bit of comment on that.
Thank you. Musa Mushavela from South Africa. So my work has been a lot in healthcare systems and trying to figure out how to reorient and reorganize health systems. And part of the big problem is that our healthcare systems currently in South Africa and a large part of Sub-Saharan Africa are designed around curative models, responding to diseases. And the idea of preventing diseases is difficult within the healthcare system, which is also what makes it difficult for people who are interested in primary prevention. They have an aversion towards the idea of healthcare systems, largely because of the way the healthcare systems function and how they've been introduced in that part of the world and how they operate in that part of the world. Now, I think that it's important to make sure that we've got the capacity to treat diseases. There's no question about that. But at the moment, when you talk about health promotion, behavioral interventions in our healthcare system, there's no capacity. And time and time again, we talk about the importance of behavior, but we never really talk about how to deal with problems that pertain to behavior. We don't like to talk about that. Most of our responses is to respond with a medical product. And even in this discussion yesterday, you hear it. You can hear that there are issues that pertain to people's behaviors, but we are looking for products that can sell. But and again, I'm not necessarily opposed to the idea of products. I think maybe combination responses would probably work better for us. But we do that to the exclusion, often total exclusion of interventions that relate to empowering people to manage their health and improve their health. And now, in that part of the world, we are now talking about how to remodel primary health care in such a way that health promotion can happen, or health services can happen outside of what is typically known as the healthcare system, primarily to avoid this trap that we have created of constantly falling into these notions of curative models. But unfortunately, I'm a medical doctor. Most of us are trained within a system that teaches us how to specialize and over-specialize. And to specialize and over-specialize also means that we need to have vertical systems of delivering programs so that we can exercise our specialties really well. And that's a challenge. We don't necessarily want to move to a level or find a balance with a level of care that allows us to be generalists. And that's why there is this division in the room. If we were to find a way of overcoming that problem, we may then be able to position ourselves in such a way that we can provide a balanced, I would say, model of care. I don't know what to call it.
So I'm going to turn this back to ask for comment in this frame, because I think a lot of these comments and a lot of what the four of you were talking about as well come back to if we see a future where more people are comfortable in the middle, in the way that's where most of us in this room wanted to be. You know, we're comfortable in the middle, but the world is boxed in different ways. Focusing this kind of intentional work around convergence, integration, all of these things, is an opportunity to be in the middle. And it's an opportunity to reframe around the person, who of course is not siloed, the person, the individual person, not patient, person, is themselves not siloed. So there's kind of a, from the person up and from the big picture down, opportunity to be in the middle. So I'm wondering, you know, each of you is in a part of this puzzle. From your part of the puzzle, what's the thing that gives you the most hope about being in the middle? What's the thing that could be most different? How could this not fall into the traps that we've been in health systems for the past 100 or 1,000 years? Where's a nugget that you see this as a complete mindset shift opportunity? Well, let's start with Dennis. I keep making Jean go first.
Well, my answer may come back to the exchange we just had a moment ago. The reports that you talked about, if I remember right, reading them, was that they were very much, as in the 93 report, around NCDs. The discussion that we were having was like, how do you tear down the silos? And the point I was trying to make is for us to get to the middle, it's not about arguing for IDs or arguing for NCDs. It's looking across and looking much more comprehensively at the entirety of the ecosystem. So it may be that there was within that document a robust discussion about NCDs within the context of the larger ecosystem. And if that is the case, that has not been communicated. And it seems to me that if we're going to get to the middle, we need to understand problems not in their isolation, but problems within within the context of the systems that you're working with. And that's where the middle place sits. So I think if we're going to get there, it is that the funding streams are going to have to be aligned with understanding that you don't invest in one or another. You invest in the health systems that people are talking about to be far more integrated and not built around silos. And so that would be my comment. And again, if that's embedded in that document, that's what I've missed. So.
Where do you see hope in the middle?
Well, I see, let me put it this way. I'm an internist, but people think that I'm a public health physician. They just don't understand me. That's the truth. And I have had questions asked of me several times. What should we call you? What should we call you? Because they see me doing all kinds of things that dealing with health from the extreme end, engaging communities, engaging families to the other end of dealing with patients. And so they just don't understand me. You said that we are comfortable here talking about convergence in this room. How can we bring other people to also feel comfortable? My bet is we are comfortable talking about it in this room, but as soon as we walk out of this door back to our offices, we'll be doing different things, not related to convergence. So public engagement is one of the things that today keeps me fired up in the sense, how do we engage the public so that they take care of their lives? As one of my colleagues, Francis Omaswa, who may be known to many of you, keeps saying, health is made at home. Therefore, make health at home. It's not going to, you come to health facilities to fix it, to repair it, but health is made at home. And so if we can adopt the attitude of engaging the public as much as possible for them to understand more, whatever health challenge they have, how could it have been dealt with or prevented at an earlier stage? I think we will make a lot of progress in that respect.
Thanks. Just to sort of pick up on one of the things that Dennis said and maybe add a little bit more to that. One of the questions in our prep material was, what are drivers behind this, we're in our different corners of the world issue. And, again, as an economist, I thought about budget lines, which you mentioned. We all know the issue of siloed budgets. It's very hard to work across those. So that has to change. It's within government and the donors as well. Training, which others here know more about. Training is often very siloed. So concretely, bringing some convergence in some of those upstream factors that then lead to the delivery. But I would go beyond where Dennis stopped, which was that will allow us to focus on health systems. We have to really get beyond the health system. Of course, we all know that there are multiple sectors that are implicated in this in terms of sort of those broader drivers. And so that's a really big thing to try to, bite off, is all these different sectoral drivers and what they're contributing. But just within government, for instance, looking at what different departments and ministries within government are doing that particularly affects prevention. So education, sports, transport, of course, just looking at what they're doing and thinking about how they could be doing it differently. I would even start with and stop with, for the moment, measuring the budgetary contribution that each of those different ministries makes to prevention of disease, whatever kinds of disease, agriculture, of course, too. And that we with PAHO a few years ago, we developed a methodology to do that. It was piloted in Chile a few years ago, and they added up. There's a framework that OECD developed that speaks to what are the actions that other ministries and departments can take that affect health prevention, affect disease prevention. And so we just used that framework, added it up in Chile, and came up with how much is being spent by all of these other departments towards health promotion and disease prevention, towards the benefit of health, not the health sector, not health services, but health. And that was a really useful exercise. And that's something that could be concretely done, I think, to help get us out of the silos. But the budget lines have to change. And then just the last thing on the DCP, the most recent one, it was funded by Gates Foundation, as was the 2006 one. It's 9 volumes, and I wanted to thank your data that you presented yesterday drew from the 9th volume. They were published between 2015 and 2018, I think, 2017, in 9 volumes. So it's all there. It's not just NCDs, it's not just infectious diseases, and that's not the only answer in the world, but it's some evidence to draw on.
Yeah, I guess I guess a couple reflections, and then to answer your question about the the hope in the middle. I guess one is just to pick up again on this point that Rachel made about convergence and what we mean when we're talking about convergence. And I think that the specific meaning that was brought out in the Commission on Investing in Health for me is a really important one that we shouldn't lose sight of, which is this opportunity really of converging health outcomes for the very poorest people in the world with what's been possible in some countries at reasonable cost, right? And in increasingly, I think that we're seeing a broad area of health, including NCDs and injuries, as part of that opportunity. There are disparities across across multiple disease entities, and that it goes beyond a few major conditions. And I worry a little bit that when we talk about convergence and you bring NCDs into the picture, there's an automatic different kind of meaning, which is more focused on development, the future, lack of absolute poverty in general as sort of the flip side of that convergence. So I think that we should remember to think about our continued focus on that kind of convergence for the poor. And I think that related to that is a little bit of a challenge to the context of this, in a way, of this forum in terms of microbial threats and the way that we tend to want to frame things in terms of epidemics or syndemics or pandemics. And there's a really important word there that gets overlooked, which is the endemic. That there are things that have been part of the problem for a long time, and we have a hard time measuring that. We have a hard time seeing it. I mean, I was looking back at the history of vital statistics, and you guys are probably familiar with this, but originally, the base of the ICD is William Farr's work in England in the mid-19th century. And the distinction that he made initially in terms of like the group 1 diseases were these conditions that he called zymotic diseases. I don't know if anybody's heard that term, but it means fermenting, I guess, in Greek. So this was, these were basically, things that were a signal that were changing, that were fermenting, that were epidemics really that public health should pay attention to, and mainly things like cholera. And then other conditions are somewhat what we would consider non-communicable diseases, although TB is in there now, like things that are not fermenting. And that's basically the basis of our ICD classification. And I think that maybe we're in an era of thinking about the things that aren't fermenting. And the importance of those. And to Bridget's comments about the health system, I think the truth is that the previous period of global health and the last 10 years that we saw really didn't need health systems. I mean, I come from probably my deepest experience being in Rwanda, having lived there for a period of 5 years over the last 10. And Rwanda is presented as an example of a country that's had relative development of its health system and improvements in health statistics. But I think the truth is that a lot of what was achieved could be was achieved in the community, was achieved at health centers without really the need for a functioning health system. And I think that we're maybe in an era where including to deal with these non-fermenting diseases. That we actually will need to deal with that complexity in those health systems. So I think that may be where we are in terms of hope.
Thank you. All right. Well, I just want to thank the 4 of you very much for coming and sharing your thoughts in this somewhat freewheeling panel that we've had going, and to all of you for your attention and for weighing in. So thank you. A round of applause for the panel in the room. I think next on the agenda is a break. A 15-minute break.